Welcome to Moving Conversations, a podcast for movement professionals by movement professionals. If you coach, train, or teach movement, Pilates, or fitness, then this podcast is for you. With more than 60 years of experience in fitness and Pilates, your hosts, Brian Ritchie and Nora St. John, explore the science of human movement, diving deep into the facts, myths, and common misconceptions, hoping to spark thought and conversation about how we view fitness and movement. Now, let's jump into Moving Conversations.
All right, guys, welcome to Moving Conversations. You usually hear Brian Ritchie's voice at this moment, but he is indisposed due to some health issues at the moment. So I will be doing this particular recording by myself, or at least with my wonderful guest, Ms. Diedra Mans. Woohoo! She's a doctor of physical therapy, and her specialty is really menopause, all of the factors of menopause, the biopsychosocial, physical, musculoskeletal, psychological, hormonal, really understanding that whole process and helping women to move forward successfully through that wonderful and unpredictable transition process. So before we get started, like and subscribe. Again, we're Moving Conversations. You can find us on Apple, Spotify, etc. We also have an Instagram page, Moving Convos, and a Gmail page, movingconvos@gmail.com. So if any of that's of interest, check us out there. And without any further ado, welcome, Diedra.
Hello. I'm so happy to be here with you, Nora. It's so good to be here.
Yay. So, Diedra, in reading your bio and also just in seeing what you've been doing and looking through your website and just hearing about you, and I've known Diedra working on Pilates on Tour. She's been one of our featured guests there many times, actually. And she really does take that physical therapy meets movement approach to things, which is what I'm always looking for in the people that do that. So, Diedra, tell us a little bit about where you are, what your background is, and what your passion of the moment is.
I love that passion of the moment. You know, I've been in physical therapy for almost 30 years. So one of the reasons why I chose the profession is because of the variety that it could give me. So with whatever experiences I wanted and the accessibility of like, okay, I can go anywhere in the world and pretty much do some work. So at this season of my life, I am working towards really spreading the word into the movement practice, and also using my own voice here and creating my own business or an arm of my business to serve women who are in midlife. So awesome. I got here through my own experiences.
and do you want to speak to those or whatever those are comfortable?
Sure. Yeah, no, I'm happy to, this. Yeah, the story is kind of long, so I'll try to keep it a little short. But for those of you who don't know, I am a breast cancer survivor. And through my breast cancer treatments and some decisions that I made about my breast cancer and prevention, I was thrusted into menopause without knowledge.
And it's cold turkey too, right? Because those kind of things don't mean you get a slow change. Correct. It's like, and boom, you're there.
Correct. So the typical time for a natural menopause to occur is somewhere between 2 and 10 years. Now, in a woman's lifestyle, that a woman's life frame is at least 80-ish on average, right? So that's kind of a blip in the lifespan. However, some women are like, oh, it takes a long time. But anyway, for me, what happened, I decided to have my ovaries removed prophylactically, which means that I had a surgical menopause.
Okay.
Now, that means that I was still in perimenopause, and I was still within that age frame or age range where natural menopause actually occurs. But it was pretty much, I was in menopause overnight. And the symptoms that came on, the challenges that came with it, the life that just kind of went into full chaos, and me not having any idea what was happening to me, or having my doctors even tell me that this was going to be happening. And to be clear, they probably didn't know either. And it was just me trying to figure things out on my own that got me here.
And that's not uncommon. Right. I
Yeah.
mean, I know particularly in women's health, I did a lot of women's health study kind of through my whole career. And so many things, for example, many medications are only studied on men, right? Because they're afraid of what they'll do for women who are pregnant or whatever else. So there's just a lot of things that that really we're not studied really very well. It's getting better. It's
Well,
certainly getting better. It's made progress. It's
yeah.
an interesting time. Yeah.
It's getting a lot better, but there's several reasons, as you were saying, that women are not studied. And I don't want to get on the soapbox on this, but I will keep it short. um, for all of the NIH funding, about 8% of that NIH funding goes towards women's health. Of that 8% of the funding, less than 1% is geared towards midlife women's health.
Right.
So you are 100% correct that all of the majority of the research, the majority of the studies, the majority of the outcomes are done by men for men and extrapolated to women.
Right.
And what we are learning more and more is that our physiology is nothing like a man's physiology. So
I think any woman who's lived a life, especially a life alongside a man, is somewhat familiar with that, just from personal experience. I mean, one thing I often say is women have such an interesting change in their hormone levels, right? So, we go through childhood and then we reach puberty, and then we have this massive hormone craziness to get through puberty. And then things kind of settle up, but then we do or don't decide to have children. Well, let's have our monthly cycle is one thing for this whole period. Then we have children or not. And so pregnancy and post-pregnancy and all those hormonal changes. And then we have menopause. Men have kind of like their testosterone goes here, it moves. At some point, it starts to decline. It's a much smoother process, just in terms of that one hormone and not all the other things associated with it. And that really changes our experience radically.
100%. And you're speaking to kind of the phases of reproductive aging.
Mm-hmm.
And when I say that, it's kind of like I bristle against that term as well. But it's literally something that has been, it's called the stages of reproductive aging workshop. Really, it's called straw plus 10. And this is one of the ways that we in the menopause community are able to help to classify a woman's space where she is in her reproductive life. Okay, so
Uh-huh.
you have named like pre puberty, which is, one phase, and we have the puberty phase, right? Or the reproductive phase, which is when we start to create the eggs so that they can be fertilized and we can reproduce. And then we move into the perimenopause phase. Then we have one day on the calendar, which is menopause, and that is a 12-month time frame where you have no menstrual cycle. And then after that, you're postmenopausal.
Right.
Now these stages get broken down into even smaller stages to help us get more refined as to to understanding where a woman is in space and her menopause journey. But that's pretty much the scope of it. And you're 100% right that when men are aging, their testosterone, as well as ours, we have testosterone in our body. It declines gradually. It starts in our 20s, by the way, but it
Mm-hmm.
declines gradually. But when we are in perimenopause, our estrogen and our progesterone fluctuate wildly, wildly.
Yep.
One moment in the day, it can be as high or even higher than it was in your reproductive ages.
Mm.
And the next hour or so, it could be down in the dumps.
Wow.
And this is the chaos that women are feeling in their bodies. It
Uh-huh.
is true. This is the physiology is real. What you're feeling is really happening. Okay.
But the body's in a different environment every moment, right? So
Yes.
under different influences, like continually throughout the day, throughout the month, throughout the year. Yeah.
Exactly. Exactly. So yeah, you're 100% right in that. Um, you know, the aging process and what we are dealing with is very different than what men are dealing with. And I think that if one of the missions that I have is to bring awareness to that And that awareness often kind of settles women. It's just like, oh, I'm not crazy. This is really happening to me. And I think that settle from them, when they're more settled, they can make better decisions about their health, right?
Yes, absolutely. So just again, just being validated that you, again, you're not crazy. This is what many other women have walked this path before you. Most of us have come through it one way or the other, right? And found some solutions for it. So the next piece I wanted to really bring up with you is you have now been working on developing some techniques and some methods for helping women through this process. So can you talk to some about that and the process that you go through and whatever piece of that you want to bring forward?
Sure. So what I have discovered within myself, um, is that the menopause transition is a total life event,
Yeah.
right? It's not just a physical event. It is not just an emotional event. It's not just a cognitive event. It's not just a contextual event. It's not just a societal role event. It is all of those things happening at once during this season. So although I am a physical therapist and that's, my primary work, I have also, in the time that I've done my trainings, have stepped into life coaching and through a cognitive behavioral therapy lens. Now, I came to that through my own challenges, and that's another story. But everything that I teach, I experienced myself. And I'm like, oh no, people need to know how to do this. People need to know how to navigate this because this is real. And so the programs that I have created is right now I'm looking uh, at creating, not looking at creating, I have created a program called Stability Before Performance. And it's pretty much a framework that I've created because women like us, high performing, high achieving women, we are used to performing at a higher level, but perimenopause and menopause can be the great equalizer. Is what I say. It can be the great equalizer. So, how can we stay in that performance mode when we're unstable, right? Because
Yeah.
when we're going through perimenopause, many women, including myself, felt like the rug has been ripped from underneath us. The stability that we've been standing on, what we know have to be true, even if our cycles were, not doing us any great service, or meaning that they were painful, but we knew that they were going to come every month, and we knew that we were going to act a certain way and things were going to be a certain way. And that happened to us for 30 plus years. But then all of a sudden, perimenopause comes in and that changes, it disrupts everything. It disrupts every cell in our body. So we are in this, just by the nature of what's happening, we're in a place where we're unstable. So what I like to do when I first start to work with women is create stability in all four of those systems, or five of those systems that I've mentioned: physically, mentally, and emotionally, cognitively, helping them with relationships, because that also gets a little interesting at this time, helping them with helping them with their work lives, and again, helping them make the best decisions about their health. So, and to also create that stability, meaning it could be that we get hormones on board. It could mean that I'm helping them with movement and physical therapy, decreasing pain. It could be that I'm coaching them in an experience that they're having that is heightened because their nervous system is dysregulated, because their nervous system depends on constant, reliable estrogen and progesterone, which is no longer there.
I love this idea because so often what we work on in movement is stability versus mobility, right? And
Exactly.
we often are creating stability there as well. Just thinking of just the myofascial system, but I love this three-dimensional stability model. I'm often think about my sister, who's 9 years older than me, and she's a lawyer. And when she was going through menopause, The few things she said were, one thing she said was, I have lost the ability to multitask, which as a lawyer is a little tricky. Also, she's often in a room with a whole bunch of men for a deposition or whatever, and a hot flash comes and she's suddenly beet red and sweating, the awkwardness of that, and just feeling like the skills that she had and worked with as a professional woman were not available to her, and rather suddenly and also unpredictably. Sometimes you'd feel like you're good, and sometimes like I don't have no idea what I'm doing here.
100%, and that has to do with that wildly fluctuating estrogen and progesterone that is happening. And and also during that time, during the perimenopause transition, we do lose our capacity for, momentarily. I have not been pregnant, so I can't speak to this experience, but it has been likened to what happens to women post-pregnancy, where they lose all of the abundant estrogen that they have to help them create this baby, but they lose that and they start to lose their cognitive abilities. But then it starts to improve and get better. From what I understand, it never gets back to where it was before, but that's the same thing that happens here in menopause and perimenopause. We have this window in perimenopause where we actually do have a bit of a cognitive decline. And we see that there's a change in energy in the brain, because our brain energy is governed by glucose. And that glucose is governed by estrogen to get to the brain. So, so now it makes a little bit more sense, right?
Well, so many reasons why things get a little crazy.
Yeah.
So this is fascinating, and I love the fact that you're putting this together again in this very three-dimensional whole person way. Because so much of what we talk about in terms of movement is, yes, we're movement professionals, but oftentimes that's not all we ever work with. Many of us do oftentimes, I would say, casual coaching of our clients, certainly supporting our clients in various ways for better, and with more or less skill, honestly. But that's oftentimes part of our role too, is just helping people go through difficult transitions, whether it's pain, whether it's menopause, whether it's just, a difficult thing in life that they're going through. So can you talk a little bit about specifically the myofascial effects of perimenopause going into menopause, and how you work with that?
Sure. So a couple of years ago, some of your listeners might know of Dr. von der Wright. She is an orthopedic surgeon. She's one of the menopause influencers in the world right now. And she and her team coined this nomenclature called the musculoskeletal syndrome of menopause. And that was back in 2024. But to be clear, prior to this claim or this nomenclature being put out in the universe, many other researchers, there's lots of other research prior to that 2024 study that has identified this musculoskeletal syndrome, but now it's official. Okay.
Sometimes
we just need to put a name on it, right? And the reason why the team, von der Wright and her team, decided to do this is because it encapsulates many different diagnoses and conditions, which I'll talk about in just a second. But that nomenclature can be used throughout the healthcare system and the medical system. And I believe that it's starting to get much more traction now, because it's starting to identify these symptoms and these signs and these conditions that are related to menopause, okay, and the change in our hormonal profile. So I think that that's going to do nothing but help practitioners understand what women are going through, because several times more times than not, women will go to a healthcare practitioner seeking care, and everything looks, quote, normal, or normal for the age, and she gets brushed off. So hopefully this will get us to a place where we are being seen more. So
identifying something, again, especially for the medical system, I've seen this many times in my, 30 plus years of doing this. Once it's recognized, then it's dealt with or managed or figured out or talked about. Until it really is identified as a thing, it's like, oh yeah, they're going through something, blah, 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 blah. And also it is a little bit amorphous. It has lots of different presentations. It's not one symptom or one specific set of symptoms. It's a variety of different things. And that always seems to confuse the medical profession for good reason. It's like, what are we doing here? What is actually happening?
Yeah, absolutely. And we can put a pin in the whole medical system's education and why that, the lack of that is occurred in the menopause space. But to answer this question right now, the musculoskeletal syndrome of menopause impacts the fascial system, everything pretty much dries up, right? So the fascial system dries out, and we lose that pliability of that system, which then also puts us at a higher risk for injury of that system. Right? Does that,
And any kind of thing, right? So it can be a tendonitis, it could be a cartilage damage, it could be just a muscle sprain or strain, right? Any of those things.
Yes. So from the myofascial system, it impacts not the quote, the fascia as what I know that fascia, depending on who you talk to, right? Depending on who you talk to, we can say that fascia is a covering, right, of tissue and organ systems. From that perspective, that's what I'm speaking of, right? The muscular system is really impacted as well as we start to lose our type 2 muscle fibers. We start to have a greater incidence, not incidence, but greater rate of sarcopenia after menopause, because our type 2 muscle fibers start to decline. Why? Because the satellite cells that make those muscle fibers are also governed by estrogen and have estrogen receptors on them. No estrogen, no lower satellite cells. Does that make sense?
Yeah. No, that's good. This is what it feels like. It's good to know why.
Yeah. And within just sticking with sarcopenia, we will see that women will, during this perimenopause transition and into menopause, we start to lose somewhere between 0.6 to 1% of our muscle mass and girth per year. Okay. Not only does that happen, but the strength of the muscles that we do have start to lose their strength because why? There's estrogen receptors on the myosin heads. So the strength and the force of the contraction is going to be compromised because, well, there's no estrogen to support that. Additionally, I'm not done yet. Additionally, because we start to lose those type 2 muscle fibers, we get more fatty infiltration into the muscle. So now we have muscles that look more like a ribeye or prime rib versus a filet mignon steak, which is what we really want. So
we've got, just to reiterate, so we've got basically lots of type 2 muscle fibers, or decrease in that, a decrease in muscle strength just because of the myosin challenges. And then you also have infiltration and then just loss of muscle tissue, and then infiltration of that with fatty tissue instead of muscle tissue.
Correct.
None of which lead to an increase in strength or resilience or endurance, I'd imagine.
Correct. Which is why there's so much talk in the world about doing strength training.
Yeah.
Okay. But that's one reason why. And we can come back to that a little bit later in the conversation. Now, when it comes to bone, there's also some interesting findings there. Both progesterone and estrogen impact what the bone is doing and the bone resiliency. So estrogen is in charge of keeping check on and promoting those osteoblast activities, those bone building cells, right? Progesterone is in charge or helps to keep check on the bone breakdown cells or the osteoclasts. We now have a challenge with both of those being gone or declining, such that we see somewhere between 10 and up to 20% of bone loss during the perimenopausal transition. During that 2 to 10 year time, we have seen women, and the studies are showing that women can lose up to 20% of their bone mass.
A lot.
I have treated and have discovered osteopenia in several of my clients. I have seen, they come in with a certain presentation and they've broken a bone, and I'm like, that low force trauma shouldn't have broken your bone.
Right. Right.
Yeah.
Shouldn't have done it.
No. And these are women who were in their late 40s and early 50s. And then I advocate for them to get a bone density scan. And sure enough, they come up with osteopenia. When we also know that it's not until 65 that we are starting to see that 65 is the age where we are recommended that we get a DEXA scan.
Right.
Right. For most women. Now there's other diagnostic criteria that would certainly get someone a DEXA scan prior to 65. But what I'm saying is that women need to understand that this is also a silent but deadly disease, right?
And can happen much earlier.
And it can happen much,
because menopause can start, in your 40s, right? I mean,
correct.
Many women enter actual menopause and perimenopause in their 40s, certainly in their 50s. So that gives you 15 years or more of bone loss and hormone changes for the bones to change. So by the time you're getting your first DEXA scan at 65, there's a lot of things that could have already happened there. Yeah.
100%. And for people like me, or women like me who have either had an oophorectomy or their ovaries removed, or a hysterectomy, or both,
right,
really do need to advocate for getting a bone density scan prior to 65.
Yeah.
Okay. So we've talked bone, we've talked muscle. Let me just see, cartilage. So yes, you spoke about cartilage earlier as part of the fascial network, and you're 100% right. The cartilage starts to degrade faster, and we start to see more incidents of osteoarthritis in women. I'm just checking here to make sure I've got everything. We talked about sarcopenia. Yeah, no, I think we've covered a good bunch of it, but there's also those inflammatory conditions. This is an important one. Sorry, we didn't cover everything. So from that fascial perspective, this is where we start to see frozen shoulder.
Right. Yeah. Yeah.
So somewhere between 60 and 70% of the people who get frozen shoulder are women in their midlife years. Now, they still haven't identified exactly what the cause is yet. That is still up in the air, but there's lots of evidence out there and lots of research around this change in the estrogen profile and how it increases our metabolic resistance, i.e. insulin resistance. And that connection is related to or correlated to the onset of frozen shoulder.
I understand in Japan it's called middle-aged woman's shoulder would be
yes.
That's the translation for it. There could be apocryphal, but I thought that was kind of appropriate.
Yeah. Exactly.
Yeah.
So we have those tendinopathies, plantar fasciitis, gluteal tendinopathies, all kinds of inflammatory conditions, because estrogen and progesterone and even testosterone have a role in anti-inflammation in the woman's body, primarily estrogen. It's a very powerful anti-inflammatory substance within our body. So sometimes we can just wake up feeling, at 40 something, feeling not so great.
Yep. and that's that more generalized. I've talked to so many women, and it's like, just everything aches, everything feels funky. Things are not as easy as they used to be. They often get much more post-workout soreness and don't recover as quickly, all those things. Yeah.
Yes, that is really true. And thank you for bringing that up, because one of the things that is required that's very different in training a woman in her perimenopause and menopause, frame of her life, is that we do need more time for recovery.
Mhm.
Much more time. I mean, not only between bouts and sessions, but literally even between sets of exercises.
So it's going to be more like if you're doing something a more traditional weight training version, do a set instead of like the usual, what, I don't know, 15-second, 30-second
Well,
break.
it depends on what you're training, but if
Yeah,
we're
yeah, yeah.
training for hypertrophy, it's somewhere between 60 and 90. If we're training for strength, it's 2 to 3 minutes.
Right. Okay.
Okay.
Yeah. Good.
So yeah, so and we it's really important that we start to consider that. And it's much more than that. That's why, I did this whole workshop on it and have, lots of thoughts about creating much more than just that 3 hour workshop on it. But it includes a lot more for us to consider, and our exercise parameters, right? Um, so yeah. And in the Pilates world, I don't know if this is where you want to go with this part of the conversation, but there is this I don't know if you've seen out there in the universe recently that Pilates isn't enough.
Uh-huh. Right.
And and so and that Pilates is great, but it's not enough for women. And we it kind of took me down a rabbit hole a little bit, because I was like, what? Pilates is not enough, but it's true. Pilates has a great place in the progressive resistive exercise programming.
Yeah.
It is it is got its own place within that continuum. But when we're talking about building the amount of strength that we need to build in order to build muscle and bone, it does not exist in the Pilates environment.
Yep. Exactly. No, I'm very clear on that. And that's,
Yes.
and what I often say, and I say this about Pilates anyway, is Pilates is an excellent foundation. It creates good movement patterns. It creates kind of fundamental integrated strength that then you can load. Right. I mean, that's oftentimes I feel like its place is to create a body that works well enough to then load more heavily without causing injury, or to do more work, even endurance wise, without causing injury. Like that's oftentimes I feel like its role is yes, it does some amount of strength training and mobility and all that other stuff, but really its role is to create a well functioning body that then can go on and be loaded, be added to resilience or endurance or other kinds of things. Is that
Yes,
kind
I
of how you think
agree.
of
I
it?
That's exactly how I feel about it, and that's where I would love our industry to go towards, for
Yeah.
if we are working with this population of women. I would
Yeah.
love to have that's part of my mission, is to teach our practitioners, exactly, because we don't learn about. I mean, I learned about this through physical therapy, but in the Pilates environment, I did not learn the different parameters, the different exercise variables, and how to manipulate them in
Right.
order to get a specific goal.
Well,
Now, I'm pretty sure I went through Polestar, and I know what Polestar looks like, and I educated the Polestar program and love it, but it did not teach me that. And I'm pretty sure Balanced Body doesn't do that either.
we have a
Right?
little few movement principles about that, or at least we did. I'm not sure if we
Yeah.
still do, but we did.
Yeah.
Yeah.
Yeah. We do have our move and Polestar. There are those movement principles, but to really get, I mean, there's something like 9 different exercise variables that can be manipulated for a specific goal.
Right.
So what I have started to do is introduce in my own work, this is how I work here in my practice, is as I'm sitting in that space between the couch and the gym, or the rack, right, in my Pilates studio, my physical therapy practice, I'm sitting in a space where, yes, you're right, using Pilates to improve movement patterns, using Pilates to improve proprioception, to improve just self-efficacy, to improve, functional movement, and posture and alignment, and understanding how the body reacts to load, right? And then my job is to then introduce a load that is external outside of the Pilates equipment, i.e. barbells and, dumbbells, to help to load the system so that they can then go into a gym and do the amount of strength training that needs to be done at a gym.
Love
Right.
it.
And right.
Yeah.
So that's kind of where we can sit in this continuum. It's not an either or, it's an and.
Yep, exactly.
Right. It's an
Yeah.
and.
Yeah. I love that. I think that's exactly right. And I think being honest about it is important.
Yes.
Because I know I've seen some of the studies on osteoporosis and what it takes to actually at least maintain or maybe improve bone density. It's a lot of work. This is not something that Pilates is going to do terribly well. It may keep you from falling over. It may make your balance better. It may make you less likely to fall and break something. But in terms of actual bone density changes, it seems like it doesn't do what we'd hope it would do. And the weight train that is necessary from the research that I've read is considerable. You really have to. It's
if we're talking one repetition max, it needs to be above 80%.
Right.
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 And, that's what the study says that you need. This is a landmark study from Belinda Beck and her group.
Yep.
It's called the Lift More study for anybody who wants to look at it. But what they did, the average age of their participants, there was 101 participants. The average age of their participants were between 60 and 70 years old with known osteoporosis. Right.
Okay.
So one of the reasons why they did this study, because they were like, why are we not loading these women enough? If we know about load and bone, why aren't we loading these women? Right.
Exactly.
It's so they did a study that took them 8 months to complete. And what we did, I don't have the exact numbers, but I want to say it's somewhere between around 3 and 6% increase in bone density at the end of their sessions, right? In the spine and in the hip, which is equivalent to what you see in the pharmacological intervention. Right. But it does take it takes 80 to 85% of one repetition max for you to do these things, right? And that's with a back squat, a loaded back squat, a deadlift, a overhead press, and then some axial jumping. Right now, that's the summary of that study, but that's what we see.
And my understanding too, when I've read some of her work as well, is she starts out with teaching people how to do that safely.
Correct.
Which I think is what a lot of times what Pilates can help you do, is just to get that foundation going. Because, you take somebody who's completely deconditioned and has osteoporosis and you just load them up. That's not going to probably give you the result that you're hoping for. You've got to build up to that. You've got to teach them how the proper biomechanics and ways to do those things, because they are asking for a lot of load, a lot of work in a system that is potentially fragile.
Correct. And it took them 8 months to get there. I think that's what you're also saying. And that's where we sit as well. It's like, okay, let's progressively get them there. And it did take them, again, 8 months for these women to get to that place. And I think that's the take home message, is that, one of the things that, if I'm talking soapbox here, one of the challenge that I see out in the world about doing strength training, you must do strength training. And then there's a little bit of talk about, oh, well, you have to, do mobility and, you need to work with someone in order to get there. But they're all talking about, you have to lift heavy. And women are going to the gym and they're starting to lift heavy and they're getting injured without the understanding that this is a progression that takes several months to years to do.
Right. And I mean, I one of my things in Pilates that I always start with is, okay, how many women in any group, and I've taught a million years, all over the world, how many women in any group can actually do a push-up? Right? Generally very few. Even, long-term Pilates teachers, I've been teaching for 10, 20 years. I do my practice every day. Can you do a push-up? Well, I can go down an inch or two, right? And that's all they can do. And recognizing that, it's like, okay, so let's be real. And I also, again, This is a little bit of a soapbox here, guys, so just, bear with it. Because so much of fitness comes from a male perspective, and a lot of it originally comes from military training and that kind of thing, it really is based on male physiology so much. Think about CrossFit. And CrossFit, a beginning level primary exercise is a good push-up. For many of my women, it's going to take them a year to 2 to get 10 solid, full-blown push-ups. And they've got to do it progressively, or like some of you have probably experienced out there, your women go back, they say, I need my strength training. They go after CrossFit or something else, and they come back 3 months later with a shoulder injury. Right. So it's like that really is, I think, also where we can be helpful, is building up the skills progressively to be able to, again, then take that load or move that
Yes,
forward.
100%.
The same thing, but that's what we got to do.
Well, we're on the soapbox together.
It's one of the things I actually love about being in the Pilates environment, is that it is a primarily female environment, and so much of what we've learned about women's physical health and that kind of thing comes from just working with women for years and years and years, and seeing both the strengths and the weaknesses of the system for our population. And I think you've really taken that on with this incredible breadth and depth. I love it. So what else do you think of in terms of, so weight training for sure, strength training for sure. What else do you think of in terms of Pilates, in terms of the psychological work that you do with women? What other elements do you like working with in terms of helping people through menopause?
Well, if I'm putting a kind of a Pilates lens on it, and I'm thinking of the guiding principles, I'm thinking of whole body health, right?
Right.
Right. And that doesn't just mean the musculoskeletal system. It does mean everything that we've talked about already. But one of the things that really becomes a challenge for women during the perimenopause transition and even postmenopause is sleep.
Yeah.
And it is we often talk a lot about hot flashes, but primarily I would say, I think that hot flashes are experienced by 70% of women, but sleep deficits are up to about 60% of women are experiencing a sleep challenge. Either they're having a problem with going to sleep, or they're having a problem with staying asleep. Now, this has several different mechanisms that are associated with it, but long story short, estrogen and progesterone help to drive those sleep mechanisms. Okay, so when we lose progesterone first, actually, not estrogen. And that's something that people don't necessarily correlate, because progesterone production is dependent on ovulation and whether or not we're going to produce an egg. And if the egg is not produced, then we have a corpus luteum, and that corpus luteum is what produces progesterone. Now, if the egg factory is shut down or is shutting down,
why do I need progesterone? Yeah.
The progesterone is going out the door with it. And then typically we start to see progesterone decline. And the reason why I'm bringing that up first is because in this context is because progesterone helps us, is a calming, chill out hormone. And it helps us with our GABA neurotransmitters that also help us relax our system and help us go to and stay asleep.
And one of the things I know about sleep, just in a very simple way, is sleep is when a lot of our repair happens.
100%. That was where I was going to go. Is where
you build it all back up at night. And if you're not sleeping, you're not repairing.
Yeah, you're not recovering. You're not in that, we hear a lot about recovery, right? But that's really what it is. The muscles literally build themselves back up at night. The brain cleans itself with deep sleep at night.
Yeah.
The brain has its own glymphatic system that is a closed system, which is a cleaning mechanism that happens during our deep sleep time throughout the night. So this is where, one of the reasons why we see those cognitive load issues and those lack of resiliency, the irritability. So So sleep is a big thing, and one of the stability markers that I look for. It's one of the things that I really help women get when we are working foundationally is sleep. And then nutritionally wise, we also are not eating enough typically, or not eating enough at a specific time typically, and we're not supporting the systems that need really a lot. Because we're losing that muscle, we need even more protein to help us build the muscle back up than we're typically used to eating when we were in our reproductive ages.
Yeah.
Right. So you might have your listeners, or you might know that the current recommendations are 0.8 to about 1 gram of protein per ideal pound of body weight per day, split up into somewhere between 3 and 5 meals throughout the day. The other thing that women are notorious about doing, me included, because I'm a woman of that certain age that grew up with like, oh, all I have to do is not eat for, a couple of days and off 10 pounds goes. Right?
Yep.
That was me.
That was both of us, I think, one way or the other.
But what happens now instead is that when we are not eating and we're not really fueling the body, it tells the brain that, oh, okay, something's wrong. We have to survive. The brain is going to hold on to essential things that keeps it going. That is one of them. It's going to get rid of the muscle because muscle is expensive. It requires a lot more energy to utilize in the body. Muscle is going to be one of the first things to go, and it will hold on to fat.
Yep. And this is like, we've been having a lot of conversations about GLP-1s because so many people are on them. Something like 8 or 10% of the American population is on them at the present time. And I've been thinking a lot and talking a lot to women of a certain age who are in menopause or perimenopause, are already having nutritional challenges from that, and now are on a GLP-1, which again, you lose weight. That weight is not exclusively fat, no matter what you do. So you're actually sort of increasing sarcopenia potentially along with losing weight. So it's like one of those like perfect storms of, wow, how is all this going to play? I don't think we know yet. They're still studying things and figuring things out. And there's certainly some protective mechanisms seem to be happening with GLP-1s, but we'll see. There's a lot of we'll see on that one.
Yeah. And I 100% agree with you. I don't have anything else to say about that, except for I do know that I'm also, I was a former member of the Menopause Society's education committee. And one of the things that I did to help, there's a whole slide deck set for people who are becoming menopause trained and menopause certified through the Menopause Society. My contribution to that slide deck was very, very brief and cursory because it's a pretty big breadth of things that they are covering and topics that they're covering. But part of it was on weight loss and, the GLP-1s. And my part was on like, okay, you still need to exercise. You still need to fuel your body appropriately. And I think that just from a societal perspective, we are looking for the magic pill, right? Or the magic shot, right? In this case. And so if I can achieve the weight loss goal with just taking a shot, then and not doing the work towards, improving my longevity through exercise and nutrition and mindset, it's going to change everything.
Yeah, absolutely. So when you're working with, tell me a little about your process when you're working with a woman going through this. Tell me kind of what your intake process is and where you go.
Oh, thank you. So I have a very detailed intake process. So it's a 90-minute process. I send I want to say it's 9-page intake form that helps me look at really what is she dealing with from a system, a body system perspective. And then I also do, within that context of that initial evaluation or that initial assessment, I also do a mental health screen, and we start to talk about, okay, what are the challenges that you're having from that domain. And then I put, that contextual part in there, because most of the time people come to me thinking that they're having a problem with their body. For instance, I have a woman who just recently came to me because she was having some low back pain and some hip pain. We started the conversation about that, and the conversation quickly turned into a relational problem that she had with her husband. And like within that consult, it was all it like we didn't really even talk about her body. We were talking about what was happening in her relationship. and and part of it had to do with the genital urinary syndrome of menopause, which we did not touch on, but it's the vaginal changes where the vagina and the vaginal lubrication starts to dry, the vaginal tissues start to atrophy as well, and libido changes. So it was that whole dynamic as well. So I cover that biopsychosocial part within that assessment. From that assessment, we choose 2 to 3 goals that we're going to work on within a 3-month container.
Great.
And then we start to, I try not to put too many parameters on which parts or the time frames for each part, because it's fluid.
Yeah.
But we do, for the first few weeks, we're working on stabilizing the system. For the following weeks, we start to restore or reset the system. And then for those following, the last few weeks, we move into a performance optimization. And then after that, I have a sustainability where we work together once a month or once every 6 weeks just to do a check-in. So that's the process that I use in order to do that. So yeah, it really just depends on how they interface with me. But I love to come in, and I also have recently partnered with something we didn't talk about was HRT, but I recently partnered with a clinical team that's a national clinical team that will provide HRT prescriptions should that be something that a client wants to go use, which I'm a total proponent of. I am not poo-pooing HRT. It's magical for a lot of people. So, but I want to have that comprehensive approach as well.
One of the things I love about this is the last couple of sessions we've been talking about, Brian, I've been talking about like just dealing with complicated cases, right?
Mm-hmm.
And how, yes, there's the physical piece, and there's the trying to create goals that you can work with that client. And some of it is, same thing here, is identifying from a complex picture, right? These are all complex cases, complex intake. What are the, again, 2 or 3 goals that you want to work on, right? I always find I've got to get the goals pretty specific and pretty small, not small, but just specific, and not 100 of them, right? Let's just focus on these 3 things. Sleeping better, for example, or starting some strength training, or whatever the little things are. And then I also love the fact that you give it 3 months, like that's the first tranche, because all these things take time. They take time both to see changes in any of those systems. It also takes time to make it a habit. And it takes time, I find, as a practitioner to see them unwind and to see, oh, no, that's the other layer. Or something they don't tell you the first 2 or 3 times you met them, it comes out the 4th or 5th time like, oh, that's actually maybe the root issue. So we change our skill set or our desire for change a little bit differently based on what we hear over time. Because that's the thing I love about that, is it really does take time for them to become clear to you, and then to become clear to themselves. Like, what am I really dealing with? What are my real priorities?
Yes, I love that you're bringing that forward. And you're 100% right, because, when you live to your 40s or 50s, you've been through some stuff. And if we think about our bodies as machines, if we think about our bodies, I say, as cars, we're dealing with a 40 or 50-year car.
Yeah.
It's seen the road. It's seen lots of the road.
Okay. Along the way or something.
It might have had some accidents, some bumps and bruises throughout the way. And if we have an idea, if we think about ourselves as vintage cars, right, we're going to treat a vintage car very differently than we're going to treat a brand new car.
Yeah, absolutely.
Right.
I love it.
And if
Yeah.
we think of ourselves as machines, we are dealing with a body that's 40 or 50 years old. And we just need to understand that. And
Absolutely.
what happens with perimenopause and menopause, well, perimenopause specifically, is it's like the gateway to aging for women.
Yeah.
Prior to perimenopause, we are metabolically superpowered than men
Yeah.
in comparison to men. I mean, which makes complete sense because we have the ability to produce humans, right?
Yeah.
But, but once we hit perimenopause, we become metabolically equal to them. So having that 12 weeks does allow us to get down to the layers, get down to the nitty gritty, have things reveal themselves. Maybe I can't tell you how many times I've had to extend. We've gone past that 12-week initial container because
Yeah.
a new chronic condition shows up.
Exactly.
And I'm having to be prepared for that. So yeah, that is the reason why. And I appreciate that you're recognizing that.
Awesome. All right, my dear. Well, thank you so much. This was fantastic. I hope you
Thank
guys
you.
out there listening have learned a few things. I certainly have been enlightened on many fronts, which I love. We'll have Deidra's bio and also any of the links to you, so your website, etc. So send all that off to us. We'll put that in the show notes.
Sure.
So if you're interested in any of her workshops, in working with her personally, what a resource for our community. And for all of us as women, but particularly for our community. It's just fantastic.
Thank you.
Thank you so much, Diedra. It was wonderful, wonderful spending time with you. And all
so
you guys
good
out
to be
there, like and subscribe, hit your buttons, tell us if you need anything else. And for me and Diedra, thanks so much for joining us.